Division of Geriatrics Grand Rounds. I am delighted to introduce a very good friend of mine and just a true inspiration to me in geriatrics, Dr. Rachel Miller. She's an associate professor of geriatrics, as well as vice chief of education in geriatrics at University of Pennsylvania. And she's also a physician in the home-based primary care program at the Philadelphia VA Medical Center. And so I am super thrilled that she's going to be talking to us about teaching geriatrics outside the hospital. So I'll pass it off to her. Yay, Dr. Miller.
Thank you, Lee. I'm really excited to be here. And if you can't hear me, just let me know, but hopefully you can. And I'm just thrilled to be invited and to talk about teaching geriatrics outside the hospital. More excitingly, I'm really happy that this picture showed up so nicely here. This is a picture that I took recently on a home visit in Philadelphia. And I'll be honest, I was eating an ice cream cone that I bought at a corner store while I took this picture, which is just one of the benefits of being out in the community. And I'll talk about that today for sure. So I just wanted to talk about why should we teach outside the hospital? I think there are so many reasons, and I know there are a few of you here, and feel free to put them in the chat as well. And Lee, if you see them, you can add them. But I really feel passionate that we need to teach outside the hospital because so much of our trainees' time is spent in the hospital, yet we know that our patients are living in our communities and they're going out in our communities, they're hanging out in our communities, and the hospital is just not the only place where they're at. So I've really spent the majority of my career creating educational experiences, again, outside the hospital, and I'm really excited to share them with you today. And I'm excited to hear from you if you have anything that you are doing or any questions that you have for me as well. Okay. I don't know if anybody put anything in the chat, Lee, you can yell it out or not. All right, so my feeling here is where better to teach both social determinants of health and our geriatric 5Ms than where people spend their time and live. And so I really try and think with each of these curriculum that I'm going to talk about, how do we teach the social determinants of health? And we're thinking about economic stability, social and community context, neighborhood and environment, access to healthcare and education. And also, how are we teaching that geriatric assessment, right? What is so important to us in geriatrics, those 5Ms, mobility, mind, medications, multi-complexity, and what matters most. Because I think as we all know, and especially as we spend more and more time with patients, you can't think about the 5Ms in isolation. And we can't think about our patients in isolation without thinking about what is happening in their community and what is happening in their homes. What are facilitators for them in their community homes and what are barriers for them as well. And you'll see that each of these curricula go through some of that. So I'm going to go through a variety of teaching sites, which I call the where today. We'll talk about who are the learners, what are the learning objectives that we have, how and when, some of the logistics, and how some of the teaching strategies that we employ as well. If I have some evidence or something that we studied, I'll add that in too, but I don't want to spend too much time on that. But again, I'm open to any questions that you have about these different varieties that I'll be talking about. So home visits with trainees, I'm going to start with that. Lee mentioned, I am a house call doctor. Home care medicine is my passion, and this is what I do. And so at the very basic, taking out trainees with me is one of the most important things that I feel like I can do and that my other colleagues in home care medicine can do. I'll talk about what we do at Penn in a variety of different ways. But you can just see here, from those of you that can see the pictures, what we see in the home is so important. I took this recent picture here of the medications. I opened up this person's pantry. This was just like 2 weeks ago, and the home was pretty organized. And I opened up the pantry to get their meds. And I was like, oh my God. And I asked very nicely if I could take a picture and explain to him why that, this is such a strong learning point for people to be able to see. This is very confusing for people and their medications at home. And I think all of us who have done home visits have seen pictures like this. You can see on the upper left-hand corner, I have 2 residents with me. They were helping to put the tennis balls on a walker. I don't know if anyone's done that. It's actually really hard. They were sweating. It was not easy. You see a picture of medication. I have another fellow there who's helping somebody work their technology. I'm really into people's art these days. So this is an opportunity for our trainees to see who our patients are and what matters to them. And here's a piece of artwork from that patient above, another patient in an activity, a modified dementia activity. And then, just the DME and the equipment that we all order, but yet is so important for our trainees to see as well. And I'm sure that you guys can all have other examples like this. This is just a reminder of the importance of our trainees seeing what neighborhoods are like for older adults. As we're going on these home visits with them, as we're traveling in the neighborhood, they get to see these factors. Is this walkable? Is this compact? Can they get around? Is it accessible? Is it safe? What are the resources here, like community centers, parks, and libraries? And is the air, is even this just a healthy place where people can live? And you can see in this table how, we know, again, this is part of our social determinants of health that impact our health for all of our older adults. But what a better way to see that than to be out in the community. And we have this opportunity when we're taking our trainees out to discuss these important factors for health, just as we discuss our geriatric assessment. So here at Penn and the VA, we have a few different ways that we teach. One of our most successful training sites has been the start of a longitudinal internal medicine primary care track secondary clinic. That's a lot of words, but basically our primary care residents have 2 longitudinal clinics, and geriatrics can be one of them. It wasn't exactly a most favored one a number of years ago, and probably about 8 or 9 years ago, we built home visits into that. So we actually have the residents who choose to do geriatrics, they spend 1 year doing home visits and 1 year doing geriatrics. They're paired with faculty and they progress to independent visits. This really helped us take off in our geriatrics clinic. And we basically always have had 1 or 2 primary care residents elect to take our secondary clinic since we started to have it this way. They really love this opportunity to spend in both sites. Again, with the home visits paired with faculty, they get to learn about home visits. They get to eventually go out on independent visits. And then the next year they are in the clinic or vice versa. Our geriatric fellows, we've adapted this over the years, but right now they have a 2-week immersion with our Penn Geriatric Home Visit Program. And we're actually really deliberate about this. We do this in the summer or the fall. So we make sure this is an early rotation for all of our fellows. And the reason we do this is not just because we want them all to be home visit doctors, although that's really great, is because we really think that it's important for our fellows to know where our patients are living. And with the Penn Geriatrics program, they're going out mostly to see patients in West and Southwest Philly, which is the area that we serve. So they're going to see those row homes. They're going to see the senior housing, affordable housing buildings that our patients are living in. And so again, they're getting to learn geriatric assessment and how to be a geriatrician in the home, but they're also seeing those social determinants of health at the same time. Then they actually all have a longitudinal panel with our VA home-based primary care program. Our fellows have a 6+2 schedule. So when they do ambulatory every 6 weeks, they spend each of their Mondays with their longitudinal panel. They have their faculty precepted, and they also have the opportunity to go out with a variety of other disciplines. Our VA also has a partnership with a community hospital, Cooper Hospital. And we actually have primary care residents, and they have a 1-year longitudinal experience, and they spend basically Tuesday mornings every 5 weeks with one of our faculty, and they come out in pairs, and they get to also see patients locally in the areas of which they serve. I put an asterisk up here. These experiences, this is really true. It's probably one of the things I'm most proud of. These experiences have significantly increased our interest in geriatric careers and home care medicine careers. And we can see direct correlation from all of these into both our fellowship and other fellowships. Sometimes people have to leave us, and into home care medicine too. Just thinking about optimizing learning for longitudinal learners, we do keep updating their learning goals. So every few months we have a check-in and we have them follow up with something else that they're working for. So maybe in the beginning of the year, they want to learn the team or just how to do a home visit. And then they really want to learn about community resources, how to call APS. So they have a variety of different goals, but we do a frequent check-in because we do really want to keep this learner-centered. We also had them going out with a variety of interprofessional team members for joint visits if possible. This has been really great, especially on our VA side where we have this opportunity for them to go out like with occupational therapy and do a home safety assessment or do a joint visit with our pharmacist. It's been a great learning experience. And then we also make a plan with them for observation and doing. And we really feel like in the home visit venue, this is the best observation or one of the best observations for direct observation. And so even though our fellows have this longitudinal panel, myself or our other faculty will still continue to intermittently go out with them, and we will directly observe them. And we do have a direct observation form that we can pull up on our phones that we can use for them. It's pretty simple, but it provides them direct feedback there, again, based on their learning goal, so we can help them continue to grow. We do also have half-day home-based primary care experiences. All of our primary care residents have, they call it an elective, but it's mandatory geriatric elective, which includes half days doing home visits. And then our medical students do geriatric electives, and so can our residents as well. And we have some visiting students as well. And just a reminder for optimizing learning for one-day learners, we try and figure out what level the learner is. We ensure they know where to meet you. That seems really basic, but it's really important for a home visit. And we tell our faculty, think ahead about your patients for the day. Have your favorite teaching pearls ready, and we all have our favorite teaching pearls, but the more you get comfortable using them, the better you can optimize your own teaching. And then even for a learner for a half day, we're very goal oriented, and we ask our learners about their goals for their day. Have they ever done a home visit before? And what do they want to observe, and what do and can they want to do? And so we try and mix that into not just an observational, but a doing too. I actually mostly do this in an email that we send them ahead of time. So when I'm telling them where to meet me, I ask them to think about their goals for the day so that they can be prepared when I pick them up or I meet them the next day. So this has really helped make our learning much more goal-centered and less observational for our learners. Sorry about that other slide. We also have a worksheet. I've been working on this with some other geriatric colleagues from across the country. And this is the structural and social determinants of health coexisting with the geriatric 5 M's. And this worksheet you can see here on one axis has the neighborhood, economics, education, healthcare, and social community. And across the other side is mobility, mind, medications, multi-complexity, and what matters most. This has been a really great tool. We have, I give it to my learners when they come out with me, and I really have them start to think, okay, how do I apply this to this patient that I'm seeing? How does their neighborhood affect their mobility? How does their economics, affect their ability to get their medications? And so in real time, they're able to look at this and fill out, not the whole chart, that would be overwhelming, but either to take a line. Sometimes I'll say, like, think about just mobility, or think about neighborhood and built environment. There's a variety of ways you can do it, but it especially gives the students or the learners that are a little bit more timid or more observing you, it gives them an opportunity to work on something and be an active part of the visit as well. And it's great conversation that we can have outside too. So we've been really enjoying using this as well. Okay, so that's just our home visits here. So another way we get out students into the community is we work with first-year medical students for an older adult experience. This is actually part of their doctoring curriculum, so it's really early, and it's actually the first semester, and maybe this year the second semester of their first year. So they really don't have clinical experience, but the goal is to get them out and to get them to start meeting older adults. When we started years ago, we started by doing home visits, and they would come out with our faculty in pairs, and they would focus on community supports. How are they getting their meals? Is other folks coming in, like visiting nurse? What are the supports in the home, the caregivers, and on doing a functional assessment, the ADLs and the IADLs. This was very successful, but I'm going to be honest here, it was very logistically difficult for us to take out essentially 180 medical students, over an 8-week period. So then we played around with and said, is there another way for us to get them to still learn about the geriatric? Now by this time we're calling it the 5 M's and community and social determinants of health. And maybe it wouldn't be the same as a home visit, but we could still get some of that feel of experience with older adults. So actually we started doing, using our senior housing, our affordable housing that we had a relationship with. And we brought the students in and we had them in groups of 4 interview an older adult who chose to participate in this activity from the senior housing building. Sometimes we would see their apartment, which would be ideal. And sometimes the person didn't want us to go into their apartment, and that would be fine. We would go in the community setting, and they would be able to interview them and ask them questions, again, focused around the mobility and the minds and what matters most to them. And we specifically chose the senior housing building that was right in the middle of West Philadelphia, that, to be honest, is not the safest area. And so there was a lot of good conversation about safety and, again, community for our older adults here. We also had a social worker case manager who runs this building, who would give a great 10-minute talk to the students as well about resources in the community and the benefits of affordable senior housing. And then we would do a debriefing and discuss with everybody. This actually took less faculty time, and we got a lot of great feedback from it too. So we were ready and we were doing this, but then COVID hit. We obviously could not go into senior housing or to home visits. And we actually switched to a virtual interview with an older adult for the medical students. And they actually were able to choose any adult. And we did a virtual debriefing with that as well. And actually that was also really fun. So we learned from each of these experiences. This is just a quick overview of some of the conversations for the interview with the older adult. You can see some of the questions there. Again, a lot of it was focused under what matters most, but thinking about mind and mobility as well, and medication. I'm not going to read these all here, but we're in the middle of studying this now, but we have some sample quotes from each of the experience. And we really felt like there are benefits from both the home visit, the senior housing, and the virtual interview. In an ideal world, we would have all of these in the curriculum, probably at different times, actually. I think we actually feel at Penn the biggest bang for our buck for the learning for the students would be to have them do a home visit when they have a more clinical experience. But we're not yet at that point. So this year, we're actually going back to senior housing because we still do ideally want to get them out into the community. But for those of you who can see the slides here, you can see that for the home visit part, it was an intimate understanding of the patient's health and social supports. For senior housing, they were surprised to see how happy and well adjusted they were. I think a lot of them didn't know that older adults could live and get about in their community, but yet they also talked about community supports that would help them. And the virtual interview, I'll be honest, a lot of them called family members, and it was really eye-opening for them. And they really enjoyed the learning experience from a personal level for that as well. So we would definitely advocate for any of these or all of these, depending on what you have time for in your curriculum. If there's any questions, people can please feel free to speak up or put in the chat. Okay. So one of the other things that I started about more than 10 years ago was the transitions of care post-hospital discharge visit. So one of my goals for the first year for the interns was to get them out in the home, and specifically to get them to see what it's like for our patients to be discharged from the hospital. And so I knew that we had a few barriers. One is that it wouldn't make sense, nor could we have them go out with all our home care medicine providers. At that time, we definitely had fewer, and also they weren't all doing a post-hospital discharge visit. But we decided that we were going to partner with our visiting nurse, and we have a Penn visiting nurse program, and that they would go out and see a patient again in our communities with the visiting nurse who has just been recently discharged from the hospital. This would be a half-day home visit. They see 1 or 2 patients, and all of our nurses are orientated as educators for the visit. You'll see they completed a transitions worksheet and a brief reflection, and then we actually got together and we debriefed the cases. And I think that was a really important part of debriefing the cases, because everybody saw somebody slightly different. So there's a lot of group learning from this. Our other big takeaway from this is that we got a lot of people would ask me when I first started talking about it, well, why didn't you have them go see their own patient that they discharged from the hospital? And while I believe that would be amazing, logistically, that is not easy. And also they would have to go on their own, which has some safety issues. But we really felt, and I think we showed with our data here, that even going to see a patient not known to them had a tremendous amount of learning for them. And so again, making it more applicable and able to be replicated by other programs. So this is just an example of the transitions experience guide. This was, and I use this off of the references last year, I'm sorry, but Coleman, who's done a lot of transitions work, and some other folks, I based this off of that. I actually, for this year, I am going to make some adaptations and reword it with the 5 M's, but you can see it's easily going to be able to be adapted to that. This experience was halted by COVID, but we are in the process of re-upping it now and actually hoping that it will start again in a few weeks. And the interns are really excited to be going out with the visiting nurses. The nurses have been amazing. We've had, I've worked hard to get relationships with what we call pen care at home and develop, a network of nurses that were willing to be able to do this. For the most part, they're really happy to do this because they know that these interns and residents know nothing about what happens in the home. And so they feel really empowered to be able to give this, to provide this experience and give their insight into what happens at home, and certainly to help teach them about skilled nursing and skilled care overall. They loved doing the home visits. That was going great. And probably about maybe 4 or 5 years into it, they kept asking, can we also see skilled nursing? So we added this too. So this is another half-day experience where they go to a skilled nursing or rehab facility, which we also send them to one that's also long-term care. So they get to learn that as well. Again, this is our PGY1. It's part of their transitions of care curriculum. And I didn't say this before, but I lead both the transitions of care, or I have led both the transitions of care and the aging curriculum, which I believe can nicely dovetail. And it's a nice opportunity for geriatrics to get involved under transitions of care. So my original involvement actually was under transitions of care, but at that same time, I built an aging curriculum, which I'm not talking about all of that right now, but again, thinking about how to geriatrics, get into curriculum, geriatricians get into curriculum. But they have a 2-hour tour led by a geriatrics faculty or fellow. They see the facility. They learn the differences between long-term care and rehab. They meet the interprofessional team, and they review discharge facilitators and pitfalls and the discharge summary. Again, our faculty love doing this. Our fellows love doing this because they are fed up from the discharge summaries that are coming that do not understand what happens in skilled nursing and in nursing homes. So they really feel like they're helping to empower both themselves and the trainees that are coming. So this is a highly enjoyed activity as well. This took a hiatus with COVID, but is up and back and running. And we just completed it this year again. So we're super excited to have that happen again. We do have a reflection prompt that we have them write. I actually have them do it for both skilled nursing and for the home visit. I just put the skilled nursing one here. Asking them, how has this visit changed your perception of discharge? Will this experience change the way you care for patients? And did anything in particular surprise you on the visit? I think this is an important part because it makes them stop. We only ask them to write a paragraph or two. But it makes them stop and think, right? Okay, well, what did I learn here? And then we have, like I said, we've used similar reflections for the transition visits, and I've used them for home visits too. Sometimes actually I'll incorporate readings or an evidence-based article. That's not what we do for the SNF one, but just something to think about for the future. We have studied this. I published just a few years ago. And you can see here that there was a lot of different, we looked at both quantitative and qualitative. I actually reviewed the reflections that I just mentioned for both the home visits and the SNF visits. And there were a lot of different facilitators and barriers they saw specifically around discharge instructions and med-rec, health literacy, social support and living situation, the interprofessional and post-hospital team. And they also talked a lot about patient self-efficacy in both a positive and a negative way. And so we had a lot of different comments there, and it was really great to see them talking specifically about, the geriatrics part, and certainly about the social determinants of health impacts for our patients too. And this is just the quantitative data for that. We did look at them 18 months follow up. And you can see here that many of them did feel that they had a better understanding of the discharge process and med-rec and increased roles of interprofessional team members. the performing a functional assessment was low. And to be honest, we weren't teaching that. So, something to think about, where else would we teach that? And we have other ways that we teach that as well. But this was really a fun way to look at it. I preferred actually the qualitative data for this over the quantitative data, but it's an important way to look at both of it. All right, so this is probably my favorite thing that I've done. So this is the geriatric community-based service learning experience. And so just a reminder, the definition of service learning is that the trainees provide a service, right? And they learn as well. So they're doing something, but they're also learning at the same time from this experience. And so we have, this actually started years ago with the original Reynolds grant, and then was continued, but became an integral part of the residency and for the fellows. So we had all of our, it was PGY3s at the time, and this happens for our fellows too. Tour a senior housing building or center, including the apartments, and learn about the facility's purpose, operation, and residents. So that's part of their learning. And actually, they were also provided a brief presentation on local community resources. At the same time, the trainees would present a prepared medical topic to older adults for like about 45 minutes in an interactive format. So they had to prepare something that wasn't PowerPoint, which was different for them. We gave them some materials and some ideas of how to do that. We sent them a whole email and instruction. And again, being in the true sense of community, the topics were selected by the site and included, these are just a variety: cancer screening, prevention of heart disease and stroke, diabetes, arthritis, hypertension, dementia, depression, and safety, usually like fall safety or medication safety. What was really, really fun about this is that in the beginning, I came up with some topics, more kind of like the diabetes and hypertension and the stroke topics. But the sites, the centers, and the housing building, they started, and we would always ask them, what other topics do you want? They started to add topics. So I remember early on, they really wanted depression, and they specifically wanted depression around the holiday season. So around December and January. So that's a very common topic that we do in that time. And then recently, one of our fellows did a talk, and I forget what it was. It was the senior center was just reopening. I would say she did a standard talk, probably on arthritis. And they loved her, and they asked her to come back, and they asked her to do a talk on sex over 60. And so she got to go back and do that and had a great time with them. So we're open to all talks, anything that the center wants. Sometimes it'll be linked. If it's breast cancer month, it'll be cancer screening, but we really work with the center. I've developed relationships with the different the different senior centers. Philadelphia has a robust senior center community, and we have 4 right again in our West Philly and Southwest Philly area. Actually, I think it's 3 now. So we go there. And again, we have a lot of affordable housing buildings, and we've developed relationships with them as well. I will tell you, actually, just before I gave this talk, I got an email from one of the centers that we actually had not, this had been on hiatus too from COVID, but we have started now to go back out to the senior centers. So one of the ones that we always went to, but we haven't been to since COVID, just emailed me and said, we want you to come. Are you coming back out? And so they are so excited to have people come, to have doctors come. And again, they get a tour and they get to see the community and where our folks are hanging out. The goals here: increase awareness of community resources, knowledge of aging clinical topics, and this gets to communication skills. So when you're trying to sell this to the residency or the fellowship, this is not just under aging. This is really under improving their communication skills with audiences of community dwelling older adults. Just another logistic things for the PGY3s, we usually put them in pairs. They liked it. They liked to be able to go together. I think they found it a little less overwhelming. And we emailed them an instructions or guide 1 to 2 weeks ahead of time. Fellows can go individually. The managers at the site meet the trainees and help set up a session. And it varies if faculty goes to observe and give feedback. I will say that in the beginning, we did have some grant funding, and we had a member of our faculty who was an administrative member who was really involved in the community, and she loved this, and she would go and sort of make sure that logistically worked out. When funding ended and she was no longer there, because we had the relationships with the sites, the managers at the sites were able to take over for that and were comfortable giving the tours and making sure that things were set up. There are definitely times that I go because I want to see how things are going and I can give some feedback. And honestly, I go because it's really fun, but I don't have to go every time because we have a way that it is working now. We do have this up, back and running, like I said, for our fellows. We're working to get it back for the PGY3 now, because as you all know, once something is lost in curriculum, it is hard to get it back. But we do, they actually, our residency really wants to get out in the community. So they do want to make this happen again. Yes. Any questions? I feel like I went through quickly, but I think Lee, you told me I had about a half hour.
I'll give a shout out to Maddie Dugan, who's on the thing too. She's joining us from down south. So anytime anyone wants to join us, glad to have you. Do we have any questions in the audience outright? Because you can definitely put them in the chat.
I have a question, Rachel. Yeah, so thanks so much. I mean, all the things you're doing are awesome and I love it. I was really interested about the virtual home visits that you do with your students, because we had done something similar. And the way we have them pick out a patient to visit virtually is with their ECMH, which is sort of like their longitudinal clinic. Right. But always, they try to have the preceptor help them pick out a good patient to do the virtual home visit with them. But obviously, there's always a student or two who have trouble finding the right patient. And so I thought that was really interesting that they did it on their own family member. And I think that's a great idea that we could tell them. And we can use that idea to say, you know, if you can't find a patient, do it at home on a family member. And I bet they did find out some things about their own family member that they usually don't bring up at the Thanksgiving table, but they're so important for their safety at home. So I love that. I also, my other question was, I mean, you've done a lot of great things, and it seems like you've developed some awesome tools that probably the rest of us could really benefit from using. Have you put any, I mean, now POGO-E is going away, but have you put anything on MedEd portal or, you know, if we wanted to, obviously we can call you if we want to share your tools, but I definitely would say, encourage you to publish them, because it looks like you've had some great ones.
Yeah, so 2 questions. One is, we were nervous about the virtual too, but we found that first of all, the other great thing about the family members, and sometimes they would do a friend or like their partner's grandparent or partner's parent or something like this. And some of the other great ones, I'll never forget one person in the last minute, I must have last minute forgot, and interviewed the doorman. And that was actually amazing. So it was just like fabulous. And we weren't really focused on the medical part, again, because they were first years, like those broad stroke questions about how do you get your medications or what is your access to medical care? And it's that same way that when they go to the senior housing building, we focus, but we were really focused on those big pictures, especially what matters most. The other great thing about the family members is that because our student population is diverse and comes from different areas, we were learning about healthcare systems all throughout the world. So people were calling family members in Japan and in Pakistan and anywhere you could imagine. And there was always like one person in the group who called somebody out of the country. And then I would deliberately bring up in the debriefing something about the healthcare system or access to healthcare. So it ended up to be very cool. Now, if somebody didn't have a family member to call or they weren't comfortable, we did pair them with a patient. Mm-hmm. But actually out of a class of 160 or 180, there's only about 5 that we had to do that with. We picked great patients and they had great experiences. But we did offer that because some people just, you know, don't have family or just weren't comfortable talking to their family. And then getting back to I was just thinking about this because I think we all just got the email that POGO-E is, you know, going to be officially over. I actually thought it was, but will be officially over in a short amount of time. So for my work, and you're all welcome to email me, and obviously I do not work alone, right? I work with other people. We have published a lot of this and published guides along the way. And so at least I hope some of the materials are there. So like the transitions visit and the SNF visit, that was published in Journal of graduate medical education. I believe those guides are there, but if not, you can email me. But I agree they should probably go somewhere. The community visit is published in JAGS. The original house calls is published. We are actually the virtual visit one, that slide, we are working on sending that to Geri Ed Corner now. It did remind me when I made that slide that I needed to review that paper that a junior faculty sent me. So, and that one we plan to, we're hoping it will be accepted, you never know, but with the appendix, with our actual tools as well. If it is not accepted there, and you obviously there's no guarantee for MedEd, our next plan is MedEd portal. But I definitely agree with you that one of the bigger issues is like, and this is why I was like, oh, it's a little odd to talk about things I've done. But at the same time, if we don't talk about things we've done in education, then we can't share. And so I think that it's really important. And I'm hoping that we can, I was thinking about when they said the POGO-E wasn't there, but there was that other website. And I saved that email that I was going to look there and that maybe I would try and put some of my resources there and also look to see what other resources are, because I'm always borrowing from other people. So thank you for bringing that up. So, and also, Sarah, I think years ago we used to have, and this is why actually they just, one of the benefits, and I didn't get to attend, but the Geri Education Conference. So years ago, we used to have the Reynolds Conference, and that used to be a real big place that educators would share these things. I mean, now at AGS, they do teacher swap. So our virtual visit actually was part of teacher swap. And one of our fellows did present that, but I don't know, I think we really need to figure out what's going to be the best way for us to share materials. Because I don't know, I mean, a lot of my things started out because I borrowed things, appropriately from other people.
Right. You give them credit. Well, if Geri Corner from JAGS, rejects you, you can always go to that geriatrics and gerontology and geriatrics education. They like a lot of education stuff.
Yeah.
That's great. And if you want to do something that's multi-site, keep us in mind.
Oh yeah, definitely. And I mean, that's another thing. If there's anything you think here that you want to do together, we can continue. I mean, I think the interesting part about COVID is some of these community things did go on hiatus, right? Not so much the home visits, because we did some of that virtual, but we got them out pretty quickly for the home visit part. But now as I'm starting to bring some of these things back, it is an opportunity to make some adaptations and also to think about collaborations and re-looking at things for the future. Definitely.
Yeah, that's a great question too, because in my research arm, I always think about how we do dissemination and implementation. And you don't really see a lot of the research for MedEd getting disseminated and implemented in like an NIH grant, which is really a shame, you know what I mean? But yeah, I think going forward, it would be fantastic. I love the idea of having the residents teach at our communities. And I see all these ideas are popping up, and
I have resources and how we.
Yeah, because we could definitely talk about doing like a multi-site implementation where we test it out and look at different facilities and see how it works. And that is an implementation study, which we don't do enough of that in MedEd, but we do a little, we do stuff like that in research world, but it's something that we should definitely be pushing because I don't think MedEd research, other than putting it and being available, and then it kind of gets lost in like that POGO-E world, you know what I mean?
Well, the other thing is you look, and I think about when I originally tried to publish the community service learning, because I said, actually, of all the things I do, that is I love it. It's my favorite.
Yeah.
When I originally tried to publish that to JAGS, they rejected it because they're like, it's too much methods. Okay. So then we gathered some more data, and the data was fine, but it really was still more of a methods, right? But we added more data. And then when we sent it, and they, sent it back and said, we really like this with whatever revisions, but they asked us for more methods. And so when I tell you, I went back to the old paper and literally lifted up and put it in this one, that's exactly what I did. And so because in education, we want the evaluation, but we want the methods. We want to know how.
Once you've shown that it works, the other people want to do, well, how can I do that?
How can I do it? Exactly. And so we have to have, and that's actually why I'm pushing, I'm really excited about Geriatric Corner or these other opportunities, because I'm really at this, I really believe we just need to get our stuff out there. The other way, Lee, that I try, and just for other faculty listening to this, where I've had success in getting my ideas out there is through workshops at national conferences. And so, I just am at AGS, but I spend a lot of my time at SGIM because I want to teach a primary care population, one about geriatrics and social determinants and home care medicine, which is, again, my focus as well, but also share these ideas so that it doesn't have to be just geriatricians who are creating some of these programs here that certainly I discussed and other people have discussed as well. So, those are other ways to get out your
Yeah,
stuff.
and I think that's a fantastic idea. I think many times as geriatricians, we go and we talk to other geriatricians, which is a great way of getting other ideas, but then like to get what we do out there to the hands of people. One of the questions that I had is that when you started doing the residents doing the geriatric talks to the communities, did you engage the residency director then, or was that part of the rotation for you guys?
Yeah, so I have this in my thank you here. All of it, I want to thank everyone here, but we had, and when that started with our Reynolds grant. So that was one of the first things I did here. And then I had a GAC at the same time. So all of this I've done with some great geriatric grants and great people. I started with that. Now, remember, all those funding ended. And so by showing this good work, and just for me, but just for you, anyone else here to think, by showing good work and having the opportunity through some grants, then you can continue to do that good work. Somebody will hopefully eventually fund you, which is what happened to me. And I ended up being core faculty in the medicine residency. I just say I'm leader of the transitions of care and aging curriculum. I teach some communications too, but like created these titles now that had funding, but originally started out. So when the Reynolds, which was the original grant, started out, it was me and another person from internal medicine. So I had a liaison, like I had somebody who I had to know in the residency, because at the time I didn't train here. So like I didn't have the buy-in from the residency, but she did. But then as I grew and she actually left and went somewhere else, I had enough buy-in and support from the residency to grow these things. But those things are really important. You have to get your foot in the door some way. So whether that's meeting a need the trainee programs have, whether in the beginning here, transitions of care was a big thing. Actually now using the term social determinants of health and health equity is a big way in. Well, I was already doing that, right? All of these things were already doing that. I just reframed the language. Like I can figure that out. We all can figure that out in geriatrics, how to reframe in order to make ourselves sellable. But yes, Lee, I did have a partner at first, but then it stood on its own with success.
Yeah, and then one more question for me. When you are doing your assessments, because I loved what you had for the prompts for the residents and the trainees to how did you like this? How did you enjoy that? Have you ever interviewed the communities, the seniors?
Oh yeah, so the paper has
kind of like what your knowledge is, you know what I mean? Because I'm thinking like you can even do like a research study that shows how a MedEd project actually impacts the healthcare of a senior,
Oh, our paper does have some senior data from the community, a small amount. We had a small amount, but we did have a survey that we would give them, and it was usually all fives. But what the best part about that is there was like an open-ended statement. They would make some comments, usually positive, or they would give ideas for other future talks. But that was something that we did do as well, which was really fun. But I think certainly was at a very like basic minimum level that I would love to see. I think there's great opportunity for that as well.
Yeah, because even if it's like knowledge, I mean, because I see what you're doing, like the pre-post satisfaction type surveys, but even if it's like knowledge about a disease itself, you know what I mean? Or how this might impact how you look at your medicines, or like polypharmacy or something like that, like to teach the residents or to teach the seniors and senior residents in the communities, and what they could know and how they would use that information for their own healthcare, like going even one step further.
And one of the things that I do say in our like preliminary email is that we want them to think about questions that they'll bring back to their primary care providers, right? Because we're just the conduit to that. But I 100%, I think there would be great room for. That was, first of all, we did that a long time ago, and could do it in such a better way. And I think now that we really have more and more, like when you establish partners with these community senior centers, they would be very willing to help to, give out the survey.
Yeah, that's outstanding.
I just wanted to make one comment. I think what you're doing is actually amazing because I had exposure to that when I was a medical student, and I was in upstate New York for my clinicals, and we used to go to these senior living centers. We used to go to these churches to do blood pressures, to do monitor their blood sugars, and that kind of gave us a lot of exposure to internal medicine along with geriatrics. And then who knew that, you start connecting with these patients, you start forming a bond, you understand, where they're coming from, seeing their communities. That helps a lot in residency as well. Because, in residency as internal, most of your patients are going to be geriatrics anyways. But that's a really nice transition, and exposure at that age helps a lot in the long scheme of things.
And the other thing that's reminded me as I'm trying to get it back into the PGY3, which I think I will, just not this, I don't think it's not going to be this year, is that my ideal goal was actually for it not to be PGY3s, but for it to be PGY2s, because they really want to learn the community resources earlier. And I think it would make more impact for them. And the other thing is, in my ideal setting, they would do it on an aging topic in their first year, in the PGY2 year, but in their individualized learning plan, or they would have an opportunity in their third year to do it again on their topic of choice. Because I think that, imagine the person who's going into cardiology has an opportunity to go out and speak about high blood pressure, or hepatitis C for the GI person. Again, the community would need to want that talk, but I think that could be an amazing, empowering experience for the residents as well, to be able to take, because we are telling them what topic they're going to be, but for them to see, wait a minute, when I'm outside of residency and I am trying to build my practice or be a part of my community, they're going to talk about what interests them too, right? But gauge it to an older community. So that's another one of my dreams.
Right.
No, that's super cool. I just love you, Rachel. I'm like, you do the most innovative, Dr. Miller does the most innovative research, especially that you can definitely see. But are there any other questions before we sign out? Okay, well, thank you so much, Dr. Rachel.
Thank you for having me. And like I said here on my
so
slide,
awesome.
I want to thank all of these people, and including you, Lee. But none of I did this because these were all my passion projects. But I obviously worked with a ton of different people to be able to do these, and I would love to be able to work with any of you. So reach out to me for sure. I think it'd be fun.
Yeah, definitely. I think it would be super fun. So thank you very much. And thank you for everyone who attended our Division of Geriatrics Grand Rounds. So awesome. Thank you guys. Signing out.
Bye.